Hello, my name is Omar Jundi. I'm an intensive care registrar and anaesthetic registrar and member of the Adult Critical Care Training Group. The role of this video today is to train you or teach you how to provide an intubation for a suspected or confirmed Covid-19 patient. I cannot emphasise enough to you the importance of maintaining your own safety during this procedure. Intubation is one of the most aerosol generating procedures that any anaesthetist or intensivist will be involved in regularly. It's for this reason that we are very keen to emphasise the importance of adequate training in PPE and donning and doffing of your personal protective equipment. Clear communication during the intubation process is essential. There will be a lot of tasks that are very different to a normal intubation process, and making sure that you are heard clearly amongst the rest of the team will ensure that your safety and the patient's safety is maintained. This is inevitably more difficult given the masks that we will be using, but we have to make sure that we speak slowly, clearly, and with an adequate volume to ensure that everyone is heard. The technique that we describe here will be a 4-person technique. There will be 4 assigned roles. There will be the intubator, who is the most senior airway doctor available at that time. They will be the people who perform the intubation. There will be assistant 1, the person who passed the airway equipment to the intubator. Then there will be assistant 2, who will be the person who provides the drugs to ensure adequate induction of anaesthesia for the patient, and then they will ensure that the breathing circuit is transferred from the Mapleson C circuit over to the ventilator so that the ventilator is ready for ventilation as soon as the patient is intubated. There will also be an external assistant who will stand at the door ready to pass equipment to the rest of the team as required. Before I set the scene, I wish to add one more caveat. There's been a lot of work from a number of individuals that has gone into producing these guidelines. However, they remain a work in progress. I have no doubt that over the following weeks and months we will receive feedback around this process and we will have to make small adjustments. However, we are also keen to offer guidance during this early period when we will be performing procedures that are new to us and outside of our comfort zone. The reason we are producing these guidelines and these videos now is to ensure that we have a repository to provide guidance to ensure that everyone is performing this procedure as safely as possible at any given time. The system that we have developed involves 5 essential aspects. The first of these is the kit checklist. This ensures that before we enter the room we have all the equipment that we require and prevents us from having to go in and out of the room too frequently. Secondly, we have a COVID intubation tray. These will be standardised across the trust and ensures that we can pick up and go to wherever department is required. Thirdly, we have a pre-procedure checklist which occurs outside the room and ensures that there is a clear plan and lines of communication. Fourth, we have a procedure checklist which occurs inside the room, and this will ensure that there is a clear plan just prior to intubation. Finally, there is a post-procedure checklist to ensure safety, to make sure that everything has been completed, and to ensure that there is adequate debrief. So for this scenario, we have a 56-year-old gentleman who has been on the intensive care unit for a few days. However, the patient has deteriorated over the last 12 hours, and the team managing the patient has decided that they require intubation and invasive ventilation. Now, the intubating team is assembling outside the patient's room to begin the briefing.
So all 4 members of the team would at this point be donned in their PPE as per the trust guidelines for an aerosol generating procedure. So we're going to go through our checklist to make sure that we're all sorted, ready for when we go into the room to intubate the patient. All 4 members should don PPE as per trust guidelines, and we should have all body checked that. Is anyone not happy with their PPE?
No.
We've allocated roles already, so I'm going to be the intubator. My name's Rich. Paul is going to be the first assistant. He's responsible for drugs and the anaesthetic circuit. Dawn, you're going to be the airway assistant, assistant 2, and Harshal, you're the external assistant, so you're going to stay in the ante room and pass equipment if required.
Sounds good.
If we require emergency help, then we're going to dial 2222 and we're going to declare an anaesthetic emergency. We're going to check the intubation drug box now, so we're going to use that checklist. So Dawn, can you check this with me?
Yep.
Face mask?
Yep.
OP airway?
Yep.
Subglottic suction endotracheal tube size 8 we have chosen.
Yep.
Mapleson C circuit.
Yep.
HME filter.
Yep.
End-tidal CO2 line.
Yep.
Bougie.
Yep.
Tube tie.
Yep.
Optilube sachet.
Yep.
20 ml syringe.
Yep.
Closed suction catheter.
Yep.
Tube clamping forceps.
Yep.
Fine bore feeding NG tube.
Yep.
And an intubation checklist that's in my hand. We've also prepared the following equipment. So we have a video laryngoscope.
Yep.
And we've checked the battery on that.
Yep.
We have an appropriate blade for that laryngoscope.
Yep.
Monitoring, we have ECG, SATS probe and non-invasive blood pressure on the patient in the room. There's a capnograph block in the room. Suction and Yanker is in the room, and then we're just going to run through the drugs with you, Paul, if that's okay.
Yes.
So, induction agent.
Yes, I've got some ketamine.
Muscle relaxant.
Yes, I've got rocuronium.
Vasopressor.
Yes, I've got metaraminol.
Saline flush ×2.
Yes.
Maintenance sedation.
Yes.
Fine. And Harshal, we're just going to run through the equipment for outside the room. So we have an alternative laryngoscope.
Yep.
iGel size 4.
Yep.
Front of neck access kit to include a size 10 scalpel.
Yep.
A size 6 ET tube.
Yep.
And a bougie.
Yep.
We've got a spare endotracheal tube.
Yep.
We've got nasopharyngeal airways.
Yep.
And we've got McGill's forceps.
Yep.
That's great. So to complete the checklist outside, the patient's weight is
70 kilos.
and their drug allergy status is.
There are no known drug allergies.
We've checked the drugs already. In terms of difficult airway procedure, so plan A was going to be indirect laryngoscopy with our video laryngoscope. Plan B is going to be using a supraglottic airway, which Harshal will provide us with if we require. And plan C is going to be front of neck access. Has anyone got any questions?
No.
Thank you.
We are now inside the patient's room and we are preparing to intubate the patient, and we will do the checklist before doing that procedure. We will apply the monitoring if it's not already been done, including a SATS probe, the ECG monitoring and non-invasive blood pressure and capnography. The intubator will begin pre-oxygenation with the APL valve closed, and we'll optimise the patient's position.
So can you apply the capnography, please?
Okay, capnography being attached.
Thank you. And there's
That will
your...
connect the oxygen to the oxygen supply.
Okay, are you ready? And we shall commence oxygenation.
Okay.
So I have a seal.
Oxygen supply on, 15 litres, and I'm going to close the APL valve. At this point, I'm going to prepare the closed circuit suction. Just see if I could have that, please. Ready for use. And I'm going to check that the cannula works with a flush. Okay. The assistant number 2 is going to prepare the endotracheal tube, syringe, and make sure it's lubricated. Once the pre-oxygenation has been completed, the intubator will announce the induction, and the first assistant will be indicated to give the drugs.
Okay, so the pre-oxygenation is complete, so you're going to give the drugs now, please.
Okay, drugs going in. Fentanyl 100. Ketamine 140, rocuronium 100, and a flush. Okay.
Okay, so they're apneic now,
Okay.
and now we're at 60 seconds. So do you want to open the APL valve?
APL valve open.
Turn off the oxygen.
Oxygen off.
I'm going to give that to you now.
Thank you.
So epiglottis, chords, it's an easy view with the McGrath. Boost through the chords. I have the tube. Tube through the chords, bougie out, please.
Bougie out. cuff up.
Okay, so the circuit. Right, do you want to touch the ventilator?
Okay, you're happy to begin
And then start
ventilation.
ventilation.
Ventilation beginning.
And we have end-tidal CO2. And we have chest rise, but we're not going to listen to the stethoscope.
Okay. So we're going to push and twist to make sure all the connectors are fitted together tightly. And we're going to tie the ET tube in place.
So that's secure.
At this point, we're going to commence maintenance sedation.
So I'll start to set that up.
Okay. At this point, we would insert an NG tube, consider invasive monitoring with arterial and central lines. We would make sure we've cleaned the video laryngoscope. We would dispose of any contaminated airway equipment. We would check our ventilator settings, and then we would leave the room and to perform our doffing procedure, including buddy checking, and have a debrief.
So this is a brief description of how we're going to go about pre-oxygenating the patient and the specifics of pre-oxygenating a patient with COVID. So we've already assembled our Mapleson C circuit as shown. So we've got the Mapleson C circuit, the end-tidal CO2 in line, a HME filter, and then the mask. And so the aim of that is to protect the CO2 line from becoming contaminated with the virus. So the first thing I'm going to do is I'm going to place the mask without any oxygen flowing through it onto the patient's face. So I'm going to apply that with a V-grip as shown in the intubation guidance. Once that's applied and I've got a tight seal, I'm then going to ask Paul, who's our assistant 1, to turn on the oxygen flow to the Mapleson C circuit. So can you do that now please, Paul?
So oxygen on, 15 litres.
And then screw down the APL valve to apply some CPAP to optimally pre-oxygenate the patient. So can you do that now?
And valve is closed.
Okay, thank you. So at that point, once the patient is pre-oxygenated appropriately, we'll then get Paul to give the drugs and I'll give him the instructions to do that. Once the drugs have been given, the patient's paralysed, removing it likewise, I'm going to ask Paul to do some things. So first of all, can you open the APL valve completely, please?
APL valve open.
And can you now turn the oxygen flow off?
Oxygen flow off.
And then once the oxygen flow is off, and only then, I'll remove the Mapleson C circuit, pass it to Paul, and I will now intubate the patient with my anaesthetic assistant.
Whilst the patient is being pre-oxygenated, it's the job of the assistant 1 to assemble the circuit to attach the patient to the ventilator and ET tube. So the closed circuit suctioning system will come in 2 pieces. The extension piece needs to be extended and attached like so, and the red prong needs to be removed. This is now ready for use once the patient is intubated. Once the pre-oxygenation is finished, the drugs have been given, and the muscle relaxant has worked, the intubator will intubate the patient. When the Mapleson circuit is taken off the patient's face, it will be passed to Assistant 1. Assistant 1 needs to then detach the Mapleson circuit from the capnography like so, and they also need to remove the face mask and the angle piece. This then needs to be attached onto the closed circuit suctioning so that the filter attaches onto the extension piece of the closed circuit suctioning like so. Once the cuff has been inflated, and that it's clearly that's been inflated, this can then be attached onto the airway, and the ventilator can then be attached onto the capnography. On the instruction of the intubator, the ventilator will then be started.
As part of the post-procedure checklist, it is essential to complete a debrief. This allows all the members of the team to voice any concerns and any aspects that they thought went very well. This can include a discussion of communication, safety, and any equipment problems. It allows us to develop the guidance and ensure that we can maximise your safety over the coming months. In trauma situations, we have come to the conclusion that avoiding manual inline stabilisation is the safest thing to do for our healthcare workers. Instead, we would recommend the use of video laryngoscopy to ensure cervical neutrality. As with any intubation, it is essential to have a clear communicated plan prior to the procedure. The Difficult Airway Society guidance has been adapted for COVID-19 patients. This will take a standard A to D format. Plan A will involve laryngoscopy, either with direct laryngoscopy or with a video laryngoscope. Plan B and C will depend on the operator. Some will prefer a supraglottic airway device, and some would prefer a bag valve mask technique, which should involve 2 people and an oropharyngeal airway device. Plan D will be front of neck access as per the normal DAS guidance. We've deliberately avoided the use of PPE to ensure that we can maintain stocks. I can't stress enough the importance of personal protective equipment. Ultimately, all of this guidance is aimed at protecting the healthcare workers, and without adequate use of PPE, this will not be possible.